We'll wait another just 1 minute. That's okay with people. We have others still joining us.
Sounds good.
Welcome, everyone. I'd like to let you know two things as we begin. One, that you are most welcome, and we're grateful that you're joining for this important discussion with three excellent presenters. I'd also let you know that we're recording this section, and we'll make it available to others in our learning community. And I say that very intentionally because the goal of these sessions that we're having, it's a follow-up to MLK Day, is to continue the conversation about issues of social and racial justice. So I'm sharing my screen because I'd like to start with some information to set the context for our conversation today before we begin the actual presentations or question and answer with our guests. This is a workshop sponsored by the GC Office of Diversity, Equity, and Inclusion and the Martin Luther King Jr. Day Planning Committee. And as you saw in the invitation, we are continuing the conversation on critical issues in our campus community, in our city and county, our state, and our country. So this is what I'm doing right now, is providing a welcome overview and context for the issue. Then we'll get to some issues and questions related to COVID-19 and health disparities that have developed and are continuing in some cases. How we can respond and help. We'll give you a chance to ask questions and get some answers, and then we'll conclude our time in an hour. Our presenters today are Brianne Brenneman, Assistant Professor of Public Health. She grew up in Mason, Ohio, as a 2016 Goshen College graduate with a degree in biochemistry and business. Professor Brenneman earned a master's degree in public health and health behavior and health education from the University of Michigan in 2019. Dr. Rose Alvarez Gillin was born and raised in Puerto Rico. She is a 1981 Goshen College graduate, a 1988 graduate of Ponce School of Medicine in Ponce, Puerto Rico, and a 1991 graduate of St. Elizabeth Family Practice Residency in Northern Kentucky. Dr. Gillin is a family physician and runs a micro practice in Goshen in which she combines traditional family medicine with functional medicine. Prior to that, she was a family physician at Maple City Healthcare Center and at Oaklawn. She lives in Goshen with her husband and cats. Zenton Yobera is a public health student and in fact is in line to become the first public health graduate from Goshen College. He was born and raised in Kenya, and raised in Spain. You can tell from his accent later why that is the case. He got a degree in analysis and clinical diagnosis and microbiology. And in April, he founded a nonprofit in Spain dedicated to give media representation to Blacks and brown folks and minorities in general. Again, I want to thank you for being part of this conversation. It's brought to you by DEI. At Goshen College, we seek to understand and engage and live with difference. We're committed to diversity, equity, and inclusion, and are striving to build an intercultural community of practice that takes students, faculty, staff, and community members deeper into multicultural or cross-cultural models of communication. Joining us today is our Director of Diversity, Equity, and Inclusion, Dr. Lakendra Hardware, our boss, Dr. Gilberto Perez, Dean of Students, and welcome to all of you who are here. So just a word about DEI. The reason I want to emphasize the word equity is we understand it at the college is because that's very relevant to our discussion about health disparities. Equity means an intentional focus to reduce disparities in opportunities, experiences, and outcomes for all members of the campus community. Equity is expressed in a commitment to address historical and current manifestations of social bias and exclusion, including the ways in which social arrangements and disadvantage some groups and legitimize others. This is relevant because in this country, in this state, and in our community, there's a growing representation of people of color. Here's a chart with figures provided by the US Census Bureau that state the diversity that we have in our country, in our state, and in our community. And I've highlighted in red the African American and Latino populations. We want to acknowledge that there are persistent health disparities facing Asian Americans, Pacific Islander Americans, American Indians, and other groups. Today, our focus is on COVID-19 health disparities facing African Americans and Latinos. So what are health disparities? The federal government defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimum health that are experienced by socially disadvantaged populations. And those populations can be defined by race or ethnicity, gender, education, income, disability, geographic location, or sexual orientation. And they result from a number of factors, including poverty, environmental threats, inadequate access to healthcare, individual and behavioral factors, and educational inequalities. The government likes to point out that there's a powerful relationship and a complex relationship that exists between health and biology, genetics, and individual behavior, and between health services, socioeconomic status, the physical environment, discrimination, racism, literacy levels, and legislative policies. Those are determinants of health. And our health can be influenced by a number of factors, as previously mentioned, including education, nutrition, housing, transportation, healthcare provider access, health insurance, clean water, and access to water and non-polluted air. So these are factors that explain why we have these disparities in our country and in COVID. About to get to the questions and answers here, but this background is to provide the context. So two more pieces of context. What are the kind of health disparities we have in among African Americans and Latinos? Well, you can see from these statistics that are drawn from the Center for American Progress that about almost 11% of African Americans are uninsured, compared to about 6% of non-Hispanic whites. Larger percentage of African Americans report being in fair or poor health. 80% of African American women are overweight or obese versus 65% of non-Hispanic whites. 42% of African American adults over age 20 have hypertension versus just about 30% for non-Hispanic whites. And African Americans have the highest mortality rate for all cancers combined than any other racial or ethnic groups. When it comes to Latinos, there's a higher percentage of unemployed Latinos, uninsured Latinos than any other racial or ethnic group. So that is a key factor of why there are disparities. Latinos don't report having fair or poor health as much as African Americans. That might be partly because it's a younger population in general. But one serious health consequence for Latinos is incredibly high rates of diabetes, higher than any other group. There's also a high prevalence of chronic kidney disease and cirrhosis, and increased rates of cervical cancer among women. Some of these disparities are why experts believe there have been disparities in how COVID has affected communities. African Americans have suffered 178 deaths per 100,000 people. Latinos, 154 deaths per 100,000 people, compared to whites who have suffered 124 deaths per 100,000 people. According to the COVID race tracker, which is a collaboration with Boston University, as of March 7th, 73,462 African Americans have died. That's at least 15% of COVID-19 deaths where race is known. And that last statement plays out because in some cases, the accurate statistics are not being kept on race and ethnicity, but the available data shows that there is a significant disparity. Information from the Centers for Disease Control and the National Center for Health Statistics, for example, shows Latinos have died at 18.3% of all COVID deaths, 14.5% for African Americans. So that's one indication. We probably will not have final statistics for a while as to the overall toll on African Americans and Latinos. But a number of studies, and here's a summary of 4 of them, shows that African Americans, Latinos are suffering disproportionately from COVID. They are also reflected in our state statistics. But one caveat is at the top of this chart, you'll see the state of Indiana only has data on race for COVID for 87% of the cases, 92% of the deaths, and 91% of tests, and even lower for Latinos. So these statistics are probably misleading, and COVID is probably a bigger problem in Indiana than the official statistics show because we have incomplete statistics. There have been lower rates of vaccinations from African Americans and Latinos, and you can especially see that disparity when it comes to what's happening in Indiana with low rates of vaccination among African Americans and Latinos. So with that as a very long introduction, and I'm sorry it was so long, we'll begin our questions, and I will stop sharing screen so you can see our presenters. First, Dr. Gillin, why have African Americans and Latinos been more severely affected by COVID-19? And how have your patients fared?
Well, the data that you went over already tells us some of it. There are more levels of chronic disease in these groups. And the reasons for that would be multifactorial also. But there just is more chronic disease, and people with chronic disease get sicker. There also would be less access to care for a lot of groups. One example is that the practice I'm in right now is a bit of an experiment. So I'm not accepting any form of insurance. I'm mostly working with uninsured patients, and there is a steady stream of people calling who don't have insurance. Elkhart County is very busy medically right now. The doctor's offices are mostly full. So people make phone call after phone call after phone call looking for providers. So lack of care is a big thing. And if you don't know the language and you don't know how the system works, it is just difficult to access care. So that would be part of it also. Another one would be that they tend to have more exposure because they're in the frontline jobs. So these are not the jobs where people can work from home as easily as others. So they are exposed more frequently and don't really have a choice. They also tend to feel like they're forced to work even when they're sick. So they're exposed to more people that are sick. So there's some difficulties with the way they work and their situation in which they work. I also know, and this isn't necessarily just these groups, but it tends to be maybe more noticeable, is poor nutrition and lifestyles that aren't conducive to health. And part of that is because of financial aspects, part of it is because of education, but those things contribute. When you have an unbalanced diet and don't sleep well, don't rest, can't reduce stress, you just are going to get sicker more frequently and more severely. So those would be some of the reasons for the disparities. I know that there are a lot more, but those would be some of them. You asked how my patients have fared. A lot of them have gotten COVID. Most of the people I asked tell me, yes, I had it, I had it, I had it. But I've only had 3 people that were hospitalized. All 3 were Latinos, and my practice is primarily Latinos. I have a few African Americans and some Caucasians, but primarily it would be Latinos. And 3 were hospitalized. So of several hundred that have gotten it, in my practice, only 3 have been hospitalized, and I have not had any deaths of any of my patients.
That's a lot. Professor Brenneman, what are some of the major implications or consequences of this kind of disparity? And do you think there has been progress in reducing some of those COVID-related disparities?
Yeah, this is a great question. And I really appreciated how you started off talking in this, talking about social justice, because I really do see this as a social justice issue, these disparities that we're seeing, and then the implications of those disparities. And so I want to start off by saying that the disparities that we're seeing are due to a lot of complex factors. So there's no interventions that are being done that can like solve this issue. And there are both health related implications, but a lot of it is economic. So we know, as you talked about, the social determinants of health, economics are tied to a lot of different outcomes. And if COVID-19 is so burdensome because it can result in death. And so if you can imagine the person that brings in money for a whole family losing their life, or having a lot of complications afterwards, where a lot of their income has to go towards just maintaining health, money is more scarce and can be used less for other ways of life, paying for rent, paying for food, sending their kids to college. And so there are these, I think, immediate impacts that we're seeing, but there are going to be impacts for decades due to COVID-19, and especially because of these disparities. And so when I was reflecting on the question that have you seen progress reducing them, there's programs going on nationally, but the one I was thinking about the most was how Goshen College is acting as this protective factor. So in public health, we talk about risk factors and protective factors. So these risk factors, just as Dr. Gillin said, these comorbidities, these other diseases that increase risk of someone maybe dying from COVID-19 are higher in African American and Latinx populations. But Goshen College as a place, I think, has done a really good job of protecting our students and has served as a place where students of color may see reduced risk of getting COVID-19, because this is where they're spending a lot of their time. And we're talking about things like the Big Four, and we're using educational tools that students can take to their families, to their churches, to the wider community outside of Goshen College.
Zenton, can you share a little bit your experience at Goshen Hospital? Explain what you are doing there and what you've observed by observing the pandemic, by being at Goshen Hospital. What are some of the things that have had the biggest impact on you of that experience?
Well, thank you for the question. My work is mostly in communication, to translate and deliver the message that they're trying to convey in the hospital to the Latino and Hispanic population. And since I didn't have direct contact with patients, my work in the hospital was not necessary, at least not presentially. And what affected me the most by interacting with different nurses and different physicians is the fact that for some people, they still call it a hoax. They still think it's a lie that hospitals are empty, but that's not the reality. I had a friend that had a stroke due to COVID, And when he went to the hospital, we couldn't go with him. His family had to stay out. It was just by himself with the medical staff. And that's a reality for many nurses and doctors. They're the only ones there for many patients. And that's the hardest impact. There's people dying alone, dying sad, parents without the possibility of saying goodbye to their kids. And that was really hard to see. And having people on the other side that they don't have direct contact or any type of connection with a hospital setting, denying the existence of the disease and the problems that it's causing, that was hard. That's very difficult. And that for me, that I'm not taking care of those patients. So imagine that it must be even harder for those nurses, seeing how or hearing how people, it must be like putting you down in a sense. So that was hard. Yeah.
Dr. Gillin, at the beginning of the pandemic, there was a lot of confusion about testing, a lot of delay in rolling out nationwide testing, insurance-related issues, and of course, there was low rates of testing among Latinos and among African Americans. Is that disparity now going away, or do you still see some a gap in testing and a reluctance to get tested?
I have not seen a disparity or a reluctance in getting tested right now. It seemed like I had an unofficial hotline there for a while. I was getting phone calls all the time, people just wondering where they could go, what it would cost, how does it work? And so it seemed like having a place to call. And I know the health department you could also call the health department, but it seemed like it was somewhat confusing for people. So at this point, everybody that I have spoken to who wanted to be tested was able to be tested. And most people that I talk with that want the vaccines have been able to schedule that and get it. Some of the younger people are just waiting till it opens up for them. But most of the Latinos that I have worked with have been able to get tested and get the vaccine if they wanted to.
Professor Brenneman, do you think there was a correlation between lower test rates and higher incidence of COVID? And I think you have an insight about this through your volunteer work at the Center for Healing and Hope, right?
Yeah, and it was interesting. I think over time, we've been seeing shifts in who is getting tested, when people are able to be tested. Center for Healing and Hope was, kind of the bedrock here in Goshen and Elkhart for widespread testing. And because of that relationship, I mean, public health interventions such as getting tested and testing widespread communities, a lot of it is based in relationship. So because Center for Healing and Hope already had built relationships and trust with the Latinx community, I think that helped and maybe changed what the landscape of testing looked like here compared to other places. And I think there's also a difference in and I don't think our conversation is based in this, but I've heard other people's conversations centering around why are people of color not getting tested, instead of asking, why is our system set up such that these folks maybe don't have access, or that there's mistrust with the medical system. And we know that mistrust is large, especially within the African American and Black community, which is rooted in a lot of systems that have been perpetuated, and most recently the Tuskegee syphilis study. And Zenton's in one of my classes, so I'll let him talk a little bit more about that. I don't want to steal his thunder.
Go ahead, Zenton.
Yeah, I was going to say that I see as Professor Brianne was saying, there's these two reasons, the extrinsic reason and the intrinsic reason. From the extrinsic point of view, things that we cannot control. For example, the need for a referral at the beginning of the pandemic to get tested, you need a referral. We have seen that not most, but many of the Black and brown population don't have insurance. If you don't have insurance, you are less likely to go to the doctor. If you're less likely to go to the doctor, you're not going to get tested. So the lack of health insurance, the type of jobs, most of Black and brown population have jobs that cannot be are not able to be done from home. That means that you have to commute. Commute means transportation. The lack of a reliable mean of transportation means that you cannot get to the testing centers. With the quarantine and many places were closed, we had less transportation, less buildings where they could get tested. So everything were complications on top of layering on top of each other. And that from the extrinsic part, even if someone wanted to get tested, they had the stigma and the fear of what if I test positive? That means that's 2 weeks of not working. If you have a family of 2 or 3, you have bills, you have rent, you have to buy food. These are reasons why if I was in that situation, I would maybe I may not be able to get tested, or I would decide not to get tested just in case of the consequences of a positive. Even for someone that doesn't have symptoms, asymptomatic people, they still have to make that quarantine, even though if they didn't feel bad to work and they had that physical strength. So these are 2 main reasons why I think people are not getting tested.
One glimmer of hope, of course, has been the vaccinations, which have proven to be very effective and being widespread available throughout the country. There have been lower rates of vaccinations, as the statistics show, among African Americans, Latinos. At the beginning, there was concern that that would be partly because of vaccine hesitancy, the reluctance to get the vaccination. The latest polls don't bear that out. They show that African Americans, Latino are interested in getting the vaccination. And I just read today that in 2019, Latinos had a lower rate of vaccination for the flu, but in 2020, Latino vaccination rates for the flu were actually higher than whites, which is great news. But Dr. Gillin, could you talk about some of the consequences if there is this continued disparity among African Americans and Latinos getting the vaccination? What could be some of the consequences of that?
Well, it would definitely be more illness, more exposure, more deaths. There will be less improvement in the curves that we have seen. So, but I would say, just like you, I've only had one Latino in my practice who has said he wouldn't get the vaccine. Everybody else is very anxious to get it. So I'm hoping that having the available vaccines, or having the vaccines available, will ensure that we have a healthier population. I'm just going to go back to the previous question and just mention that having the Center for Healing and Hope here in town was wonderful. It's close to where I practiced. I could direct so many patients to it directly. It was just a wonderful resource to have that in our community. And I'm not quite sure what's happening with vaccination sites, but I know that it's available for people, and people of these groups are interested in getting it based on my experience. The people that I hear that are not wanting to get it are usually Caucasians who have what I consider misinformation, or who are believing certain things about it. But so I expect that we will see high numbers of vaccinated people in these groups.
Professor Brenneman, some have pointed out that the gap in vaccinations might be more a matter of class or age or occupations than race or ethnicity. Do you think that's a major factor, or do you think there have been disparities that would be more attributable to bias?
Yeah, so this question, we were given the questions in advance, and I did some research because I hear lots of things, and I am always hammering on my students, and I am a research scientist. Like, I only like to talk about data, and that's something through a pandemic, of course, everything is fast paced. We never have enough data. And so I wanted to know what the data said. And I think that there are a lot of complicating factors. And I want to start off by saying, thinking about race and ethnicity as this proponent of like a biological reason why people want or do not want the vaccine. Race is a social construct, and this country is built on oppression of people of color. And so our systems and the policies all reflect that. And I think that that is why we're seeing disparities in vaccine uptake. But just as Dr. Gillin said, what's interesting is even the high percentage of healthcare workers that have declined the vaccine opportunity, which it really is an opportunity. But I think it reflects this value of individualism that we have in the United States, of saying like my right to choose, my personal choice is more important than protecting those around me, and valuing risk to self more, even though the risk to self is so incredibly low with the vaccine. That risk to self is more important than the risk that then being unvaccinated creates for those around us. And so I'm not surprised by uptake, but what I think the conversation started out as was saying that people of color the assumption was that people of color, especially Latinx and African American communities, would be less likely to be willing to take the vaccine, because we see that in other pieces in healthcare. We see it with influenza. We see it with mammography screenings and colorectal screenings. But it's interesting that the data is not supporting that now with COVID-19, that these populations have said enough is enough. We want to protect those around us and the people that we care about, because we've seen the way it can ravage through our communities. And just as I think it was Zenton that mentioned it earlier, that people of color are more likely to work in the service industry, and were not given time off during this. They didn't get to work from home. If you work at a restaurant, maybe the restaurant shut down, but then you weren't getting paid. And so maybe you had to find another job to help pay for things for your family. And so the risk has been really high for these populations. And there are a lot of scientific reasons for why the vaccine was rolled out to older populations first. But from my perspective, I think we should look at it with a critical eye and say, why were populations chosen to be given the vaccine when they were, and how it was rolled out? And there's a lot of privilege that comes with having access. For example, the fact that Goshen College, like employees were given access here is a privilege compared to other people maybe working in restaurants in Goshen, who are exposed to populations that aren't wearing masks, that aren't as protected as we are here, or people working in the factories. And so I think that there's a lot of layers to it, and it will be interesting as more data is collected, because right now we don't have enough data collected that can determine cause and effect.
Zenton, how do you see this issue playing out? Do you think there'll be continued hesitancy among people of color?
I think that the reason was a cascade effect. First, the fact that most of the Latino and Black population are younger. On top of that, at the beginning, the first vaccine, the one for Pfizer, had to be kept in special conditions. It was more likely to have that type of installations in white neighborhoods where they had more funds, more money. So by the time the second and third vaccine came along, we already had this assumption that Black people didn't want to get vaccinated. So we were already having that in mind and sending all these resources towards other neighborhoods where we thought it was more likely to be used, because we didn't want to misuse vaccines. So I think it's a mix between the narrative that we were telling to ourselves previous to vaccination and how we self-predicted the outcome by actually putting effort in creating that outcome. So it's hard to find a unique reason for it, because it's a little bit from here, a little bit from there, the story we tell to each other and the story we tell to the world. Because then when we get the data, as Professor Brianne was saying, it doesn't show that. And as Dr. Gillin was saying, in the hospital, they're not seeing that. So we should be careful with the stories we tell, because they help to shape the world we live in, and maybe we're shaping the wrong world by telling the wrong stories.
A perfect transition to the next question I want to ask, which is your personal impact, because I think people would want to know that. Dr. Gillin, how was your medical practice and personal life been affected by COVID-19 over this last year?
The medical practice initially was impacted by a very low volume of patients. There for a couple months, I was hardly seeing anybody at all. And then there was a transition of learning how to do telehealth visits and trying to figure out, is this good enough? Is it not? There's only so much you can do via video call. So that was somewhat difficult. But then as time went on, I was able to just adapt to the things that we need to do with the wearing the mask and expecting patients to wear the mask and wearing the face shield and things that are just kind of annoying, but not a huge deal. There was some difficulty setting boundaries with people, because people who feel they have the right to not wear masks feel they should be able to come in without a mask. And so a few situations that where there was some conflict with some patients, but nothing major. And right now it's very busy. I guess what I mentioned earlier, I spend an awful lot of time on the phone, just counseling people, even people I didn't know, people that are just calling, wondering what they can do. So it's all good. And it's part of building relationships and learning to trust one another. So the practice is very busy right now. I'm still trying to figure out the best way to move forward to care for people and to be available for people. In terms of my personal life, I was very happy to get the vaccine and just feel that I have that added layer of protection. And then I can tell my patients I got it and I recommend you get it. And I can tell them what my side effects were, and just having those conversations. And, it's been hard. My family's in Puerto Rico. I haven't been able to travel there since a year ago in January for my mother's 90th birthday party. So it's hard when my mother is that age to know that we don't have a lot of time left, and it's a shame that we can't visit in person. So that would be maybe the hardest thing. I have learned how to do Zoom calls magnificently. And so I have connected my mother and her siblings who have no idea how to do Zoom calls. We've been able to teach them all how to do Zoom calls. So my mother, who's 91, her brother, who's 90, sister, 89, brother, 86, I think, are all getting together once a month for Zoom calls. So making some connections that have been positive.
That's wonderful. Professor Brenneman, the same question for you. How has your life been affected?
Yeah, so I mean, it's been quite a year. I started off a year ago. I wasn't even living in Goshen. I was living in Cincinnati. And so I took a new job. I moved all during COVID-19. So that was quite, yeah, it's just been quite a year. And then my partner and I were also planning, like we had a wedding planned for this past summer. And so we didn't get to have a wedding, and we had rescheduled it for this summer, but yeah, a lot of complicating factors with the venue. We had to make a decision while Trump was still in office and with very little plan for vaccine rollout at the time. The most educated decision was to cancel the big celebration. And so that was, I think, yeah, one of the ways that COVID-19 impacted my life pretty broadly, but we still got married and it's great. And now we live in Goshen. And we both feel really blessed to live at, or to work at places that have set boundaries around COVID-19 and made us feel really safe to show up for work. And to feel supported and part of a community when getting together in person is difficult. And I work here, of course, and Kyle, my husband, works at Bethany in Goshen, and we have both felt really welcomed into these communities and supported even through a pandemic. So that's how it's impacted me personally. But as for my teaching, I never run out of things to talk about in the classroom. So in some ways, it's actually made the classroom more, I guess, prepping for class is easier. It's the first year, so I think prepping for class is probably difficult for everyone, but lightens my load some weeks. If there's a news article that came out and students want to discuss it, then we talk about it and we use the public health language that we're learning about in class that week. And finally, I have been struck by the mental health toll that this pandemic has taken on students. And so it has really humbled me to think about expectations, both for myself and to model that for my students, as well as talking to students about expectations for them and helping them guide expectations for the class, so that they can feel supported in the ways that they need to be supported this year, because I think in a lot of different ways, it's been just a hard year.
Zenton, what has the year been like for you?
Well, I was going into my last year of nursing and the pandemic hit. It was like jumping from an airplane and finding out that your, how is this called? Now the name just went out of my head. The parachute. The parachute is not opening. So at the beginning, I panicked a little bit. And at some point, I decided that panicking was not a choice. It's not. So I decided to enjoy the ride and just falling down. And at some point, public health happened to be an option to study for this semester, and it was some hope. I felt some hope. I pulled again, parachute opened, and I managed to land in a really nice class. I'm really enjoying it. It feels relevant. Every time I put on the news, or I like listening to podcasts and a lot of NPR, and every time I put on the radio, there's something about COVID, how it's affecting some new population, or how it's affecting by something different. And then I come to class and we're talking about it. So it's great to have that connection between real life and class life, because it's non-existent. So in a sense, I have to say that COVID-19 has been kind of a good thing in some ways, and even though it was a really bad thing in many others, but to not only talk about the bad part. And yeah, and being in Professor Brianne's class is great. If you have the chance, take one of her classes. I'm not saying it for credit, it's for real. Yeah, so far right now at this point, I have to say that it's bringing good things. It was hard to see the light at the end of the tunnel, and I can see it. I can see the sun starting to touch my skin. So that that's good.
We're about to give you an opportunity, those of you who have been attending, to ask questions. But I'd like to just do one final question, which some of you may have already thought of. Goshen College is a compassionate community. Goshen College is a caring community. There are people who are studying to in the future have an impact on situations like this. If you could each say one thing, maybe two things, people who are attending today or might see this can do to address these disparities or alleviate them, what offers or what suggestions would you offer? And I'll start with Dr. Gillin. If anybody here is watching this and said, I wish I could do something, what would you say for them to do?
First thing that comes to mind is that we should all learn how to build relationships of trust, that we should be willing to listen to one another, hear each other's point of views and not be points of view and not judge so quickly, and that we learn to identify our own biases so that we can be as clear as we can as we move forward. So that would just be the personal work that I would recommend. And always, as we build relationships, opportunities come up to serve and to help and to be advocates for others. So.
Thank you. Brianne?
I think in the here and now, get vaccinated. That's, I think, probably the easiest one for each of us to do right now as it becomes available to you. And to keep showing up, like just showing up today and seeking out information and continuing to educate yourselves and to start conversations in each of your communities around health disparities. If we're all having these conversations and bringing them to the forefront, that's the start. That's the momentum that we need. And then we can start to strategize and take action.
Do you think there are volunteer opportunities at the center?
Yes, thanks. I was going to mention that. Also, there's great places to volunteer in Goshen, one of them being the Center for Healing and Hope. As we've mentioned, they have been offering testing basically the whole pandemic, and they'll continue for a while longer to offer testing. They're also moving sites, and they serve the Latinx as well as uninsured populations in this area. And they're a really great place. Another place I know of is Mosaic Health and Healing Arts, which serves specifically the LGBTQ+ population. And they are another great organization that serves medical needs and other types of needs in this community.
And Zenton, what do you tell students if they ask you, what can I do to help? What would you say?
I tell them, first of all, do good without looking to whom, and inform education. Inform yourself instead of sharing everything that you get, even though you think, oh, this aligns with my mindset. Look into it, because sometimes we think we're sharing good information and we're just contributing to misleading information, to fake news, and that harms more than actually not doing anything. So I'll just say inform yourself, make some research, get the numbers, and look, even if you can look the opposite point of view, that's even better, because that will give you a whole picture.
Thank you. And now it's your turn. Please raise your hand or unmute yourself. Introduce yourself and ask your question and direct it to whatever speaker you would like to address your question. Or if you have a comment or response, that's also fine.
First of all, thank you to all of the presenters.
Gilberto,
Can you hear me?
you froze for a second. You can go ahead.
I don't know if looks like I'm still frozen on my end, but I want to say thank you to all of the presenters for a wonderful presentation. My only comment is that as I'm also relating to a number of Latinx folks in community, and the majority of those would be undocumented, there is a lot of misinformation out there, and they get this misinformation from social media and from some things from their native countries. So I think there are a number of people in the Latinx community that are very hesitant with the vaccine. So I'm not necessarily disagreeing with what was said earlier by, I think, Dr. Gillin. I just know that there are a number of people who distrust anything related to health, only in part because in their communities, perhaps the health system was not the most effective, and so therefore have not engaged actually quite a bit with those health systems. And now when they come here, there are really good opportunities to engage with the health system, whether you're documented or undocumented. And sometimes there is some hesitancy there. So I do appreciate the work that's being done to information. So that was my comment.
Thank you.
I just want to echo, this is Dr. Lakendra Hardware, and I just want to echo appreciation for this conversation. It's a conversation that we've heard snippets or pieces of, I think, since last year this time. And so to hear it kind of brought together a year into this and kind of look back, I think was really helpful to hear. I think the statistics that you shared at the beginning, Richard, we probably would want to make those available just to be able to soak in that information for those people that like to do that, the deeper dive into like the numbers to see. You all gave us much to think about. One of the last pieces that I'm sitting with, or pieces that I'm sitting with right now, thinking about particularly the African-American community and the historical inequity and injustices that are there, and the various aspects of conversation around what we should do, what we shouldn't, right? I think about the news coverage, and that was definitely something that was highlighted. And I think it was important to hear you use the phrase, Dr. Rose, you use the phrase as an added layer of protection, right? Seeing this vaccine as that. That's really helpful wording, because I think sometimes as we're doing this big, everyone get the vaccine, there seems to be judgment that's sometimes cast on particularly those minoritized communities because of their experience of mistrust. And it's kind of like, okay, guys, come on, get over it. Let's move forward. And it's like, easier said than done when you're not the person that, or the community or the individual spaces or identities that have been targeted. So I think those words of an additional layer were very helpful to hear. And I think that can be helpful to us to kind of hold in how we have conversations with people. And I've heard someone recently on a social media platform that I'm connected to said, when did this become about politics, right? So people are making it out a political conversation. It's really about, the experience of medical inequities or disparities that you point out, and how people have to come to terms with where we are today. So I don't know if that's comment, question, but I just want to, one, say thank you to each of you for helping MLK continue the dialogue in the conversation, but also really thinking into something that's very relevant, very now. And also has the potential to continue carrying us forward. So kudos to each of you and what you do, and thank you for being a part of our story, our narrative, if you will, around this on our campus.
there are two attendees who, hope you don't get mad at me for calling you out, but I would be interested in a brief comment from Greta on why you chose to be involved with the Center for Healing and Hope and what you've observed that's made an impact on you by that volunteer work. And then some staff work, actually.
Hi, everyone. I decided to get involved with Center for Healing and Hope because I had done some interpretation work with them before, and I wanted to help out during the summer with their new operation. And so I spent a lot of time, I did registration over the summer, and I spent a lot of time on the phone with basically everyone who got tested over the summer. And I just heard like a lot of people's stories about how they were exposed or like, yeah. And it's so easy to like listen to people's stories and be like, that was so stupid. Why did you go to that baby shower with all those people? Or why did you do this and that? But then when I contracted COVID myself, I think there's plenty of behaviors that I did that you can also criticize in the same way. So I think it was just a good way to like realize that we're all human and we all make mistakes and we all think what we're doing, we can all justify it always. And yeah, I don't know if that really answers your question, Richard.
Yeah, it does. And Dr. Renderly, very happy to have our academic dean here. Could you just reflect for a moment on the value of a new major like public health and the experiential learning that Zenton is able to participate in to our community like Goshen and what we are becoming?
Well, you know, we thought it was a good idea to add public health, and we talked about it for quite a while and really had no idea how things would line up, that it would be so very relevant and people would understand what epidemiology is and what these things that public health does, why they do them. So it was a program that was 3 years in the making. It wasn't a snap decision to meet the moment, but I'm so glad we did, because I think it really does build on the conversations that were going on at Goshen anyway, the strength of our nursing program and healthcare in general. And it's such an interdisciplinary field that uses information from lots of other places to help people live healthier lives. And so I think that Goshen brings a lot of strength to this. And in the very beginning, we talked a lot about health disparities and why we wanted that to be a focal point of the program, because we knew there was just such a need. And so I'm glad that we're getting into this work and that we have the expertise of Brianne here to help us get things going, and that we have students starting to engage and spread the word about it. Because I do think it's just really important work, and I'm glad that we're starting to do it.
Thank you. I'd also like to affirm Professor Yoder and Professor Meyer-Reimer, who have had an emphasis for years in their teaching about the importance of recognizing disparities in education and health and so many other factors. I just wondered if you want to share a comment or two.
Well, you're exactly right that inequities in education have existed for a long time too, just as they have in healthcare. And I think as we have had to move into remote settings for teaching, due to the pandemic, we are doing the same thing we've done in the medical world, which is unearthing or bringing out into the open some of the inequities that have been there all along, but have maybe been a little more covert or a little less noticeable, and they're getting much more noticeable at this moment when it's very clear that some people are much better set up to do remote learning and receive it because of all sorts of things, everything from technology to who's available to help younger children during the daytime to who has what kind of equipment and can do what kind of other support. So it has unearthed an awfully lot of things. the real test now is, how do we meet those? Schools are trying very hard to meet some of those. And we have a ways to go. Some have done it much more successfully than others. And different parts of the country have tried various different things, and we'll need to look at the data on that. But this story is just beginning, actually, because these are students who have been out since a year ago, many of them in remote settings. Some of them went back hybrid just recently across the US and across Indiana. And students are significantly behind where we'd normally have them be at this time, both this year, but also from the year previous. So the real test for us is coming in the next months. How do we meet this, and how do we bring children back into a school setting, students back into a school setting, and really meet their needs to, in some ways, accelerate their learning because of what all's happened at this point. So we're still way in the midst of what we need to do in education.
Thank you. And Dr. Yoder, I know you work with students who have this strong interest to try to address some of these kind of disparities.
Yeah, and I apologize for jumping in late here, but you know, I would agree, and I'm really interested in the comments how looking at the inequities in minoritized communities, you know, those trends we can see some general trends in some of the other social issues that we look at as well. And I really appreciate the comment by Dr. Lakendra about, like, we have to really understand that we are all coming to these issues from very different social contexts, historical contexts, and that part of the solution is really listening to what people need and responding with empathy and care and deep listening. And so I really appreciate the emphasis on that in this discussion today, and also just appreciate all the work that the people here are doing to like address and bring people to vaccination and to health and to address the disparities that we're seeing. So
Thank you very much. Are there any, is there a final comment? I want to share one final slide before we leave, but is there any final question or comment anyone would like to make, or any of the panelists would like to make?
I did put a note in the chat box, Richard. I'm only stating that it's just wonderful to see a Goshen College student so involved in the work. This is real world work. Zenton is at those meetings. He's getting data. He's getting information that's not public, right? So it's also providing a skill opportunity to sort of say, well, how do professionals in a professional meeting work at, you know, looking at this data and making sure it stays confidential, and right. So it's a really great world learning experience that the public health field placement is offering a Goshen College student and many other Goshen College students who are also in this field, as well as social work and other psychology areas. So just very grateful for that good opportunity you are giving, and other professors across campus in education, social work, psychology, PJCS, to our students. So thank you very much.
So the final, I want to just partly endorse what was said today about the importance of learning more. So we would encourage you to learn more about the issue and encourage your elected officials to support legislation and increase funding to reduce health disparities, to volunteer with or support financial organizations that serve those who lack insurance, or serve people of color, such as the Center for Healing and Hope and Maple City Healthcare in Goshen and Hart City Health in Elkhart. Gilberto and I are members of something, co-directors of something called the Latino Pandemic Response Initiative. And that's been a partnership of Goshen College and the health department to try to help increase education and improve test rates among Latinos. One of the things that we are involved in is involved in some early planning for mass vaccination events that the Center for Healing and Hope and Goshen Health may be coordinating. So we will let you know about opportunities to volunteer if this happens, and we do believe it'll happen. And we believe that'll have a big impact on increasing vaccination rates among people of color. And just in closing, just wanted to let you know that if you have any feedback or suggestions, please send it to dei@goshen.edu, and Dr. Lakendra and I will be happy to hear any of your suggestions or feedbacks about the session. We're also hoping to organize 2 more sessions of this type on racial and social justice issues this school year, so please be on the watch for that. And of course, be on the lookout for any announcements on ways to help with COVID-19 vaccination events or other ways to improve health and keep people safe in our community. Again, thank you very much for joining us today. Thanks especially to our wonderful panelists and Dr. Lakendra for her continued leadership on DEI, and Gilberto Perez for his wonderful support for our efforts. So again, thank you very much for participating and enjoy the sunny afternoon.
Thank you. Bye.
Bye-bye.